So clinical cultural consultation attempts to apply the cultural consultation model to the health and well-being of individual patients in the healthcare system, and we've also adapted it to apply it more widely to teams and organisations and commissioning processes, and there are also implications for society. If I come back to the clinical consultation as it applies to patients, we know that black and minority ethnic groups and refugees and asylum seekers all suffer disproportionate levels of contact with the mental health system. It's exemplified most vividly in the higher levels of detention and admissions amongst black Caribbean people and increasingly amongst black African people. It's also demonstrated in the higher suicide rates compared to white British people of the same age in black African and black Caribbean people. So the question is, why does this go on and what can we do to address it? Clinical cultural consultation assumes that there is something in the interaction between the professional and the patient, which means that the patient doesn't engage or doesn't seek help, or that the clinician isn't able to understand the patient and intervene effectively. So the purpose is to explore the patient's cultural beliefs, values and way of seeing their own health and well-being in a more detailed and in-depth way, and to know the patient better, to know where the patient is coming from, not just to know about their symptoms and the diagnosis and treat them as if they are similar to all other people with the same symptoms and diagnosis. One of the solutions to inequalities in the mental health care system has been education. Let's teach people about other people's culture. Let's try and get people culturally competent, and there have been whole political programs around this. The Delivering Race Equality program wanted everybody to be culturally competent, to have some training. Unfortunately, that training did two things. Firstly, it assumes that cultural competence was knowing a bit about somebody else's culture, not really knowing the person, but knowing a bit about their culture. And secondly, that it was something to do with human resources policies, and that actually cultural competency was about improving the recruitment of black and minority ethnic groups into the workforce. And unfortunately, the two things together don't really address the problem. The assumption that cultural competence was also an educational intervention was belied by the fact that many people had this training, but it didn't make much difference to the overall rates of detention and admission, and many people continue to say that they're dissatisfied with the care they receive, and indeed staff from black and minority ethnic groups still complain of harassment and bullying in the workforce at times. So our conclusion was that cultural competency is actually a more deep-seated process, that actually to achieve cultural competency you need to have a developmental process that touches on all the beliefs and values of the clinician themselves as well as the beliefs and values of the patient. So cultural consultation makes sense of the individual's presentation if they're unwell or feeling that they have mental distress, not only in terms of what they're saying immediately and in terms of symptoms, but also in terms of their heritage and the way they see the world. But it factors in the way that the clinician and the way that the system sees them and the limitations that are imposed upon what is normally seen as a pathology or as a problem and how it's treated. This also offers all sorts of alternatives to intervention, so that interventions aren't simply medically based pharmacological interventions or even psychologically based, but that psychosocial interventions and cultural interventions are accommodated within the treatment plan.